Hello everyone. Now let's continue this series of how to diagnose and manage a case of fever in OPD. In the previous two videos, we have discussed the clinical features and investigations. Here we will discuss the treatment of fever, undifferentiated fever. Hopefully you know what is the meaning of a undifferentiated fever. Undifferentiated fever means that there is no systemic specific cause. Fever is present for more than 2 days and fever is more than 101 degree Fahrenheit. Important causes are dengue fever, malaria, typhoid, leptospirosis, scrub typhus. So let's revise it once again. Intermittent fever, chills, pallor, splenomegaly. Clinical features. Investigations, rapid diagnostic test for malarial antigen is positive. Smear, peripheral smear shows malaria. This is malaria. So how to treat the malaria? If it is Plasmodium vivax, we will go for treatment with chloroquine. Total dose is 25 milligram per kg. So 10, 10 and 5. Like that we give it for 3 days, and along with that for radical cure primer-quine will be given for 2 weeks. For the detailed discussion on the malarial treatment, you can watch our previous videos on malaria. Plasmodium falciparum is treated with artesunate. 200 milligrams OD for 3 days should be given. Along with that, sulfadoxine 1500 milligram and pyrimethamine 75 milligram on day 1. This is for adult patients. Weight is 50 kgs or more than that. Patient complained of retroorbital pain, headache and rash. Petechiae are there, tourniquet test is positive. So now you can diagnose with the help of clinical feature, it is a case of which fever. Investigation will help you NS1 antigen positive or IgM antibody positive for dengue fever. Treatment, paracetamol is given 500 to 650 milligrams 3 times a day or maybe as and when required. Do not give any other non-NSAIDs. IV fluids will be needed or maybe oral hydration is needed in the management. Come to the next, undifferentiated fever. Patient has headache, pain abdomen, loss of appetite, relative bradycardia, rose spots, coated tongue, and typhoid is positive. Blood culture is positive for salmonella. So this is a case of typhoid fever. So let's see how the typhoid fever will be treated. We give cephalosporins for at least 10 days. That is cefixime 400 milligram twice a day for 10 days. And most of the doctors, they do add in view of resistance chance azithromycin 1 gram per day for 5 days. Ofloxacin or fluoroquinolones, they are nowadays in India, they are not given because of the resistance risk. But we have seen so many prescriptions that cefixime plus ofloxacin combination is given. Remember, combination is not preferred of cephalosporin and ofloxacin. While the geographical area is such that patient are responding to fluoroquinolone, then there is no harm in giving ofloxacin 400 milligram twice a day. Arthalgia is the main complaint. Rash is present. IgM ELISA is positive. Think of chikungunya. Paracetamol is given 650 milligram 3 times a day, but we can use other NSAIDs also, analgesics also, because the main problem of the patient here is the joint pain, characteristic joint pains. Ibuprofen can be given 400 milligram 3 times a day, naproxen 250 to 500 milligram twice a day, or diclofenac 50 milligram twice a day. But remember, these can cause gastritis. So along with that, we have to give PPIs. Patient has red eyes, abdominal pain, and a transient rash. Jaundice is there, oliguria, hematuria, hemoptysis. Always suspect this is a case of leptospirosis diagnosed by rapid diagnostic test IgM antibody, leptospirosis. Doxycycline is given twice a day for 7 days. Fever, headache, myalgia. There is a rash and lymphadenopathy. Rapid diagnostic test IgM is positive. Scrub typhus. Doxycycline twice a day for 7 days. Now come to the localized infections. Localized infections, depending on the clinical features, upper respiratory tract infection, bacterial pharyngitis. So we have done ki sore throat will be there or sinus tenderness will be there. So if it is a bacterial pharyngitis, amoxicillin 500 to 1000 milligram 3 times a day for 1 week is given. For sinusitis, we give co-amoxiclav 1 gram twice a day for 1 week. And for detailed discussion of upper respiratory tract infection, you can watch our previous videos. Lower respiratory tract infection pneumonia in the OPD without any comorbid condition or any risk of multi-drug resistance, like patient has not taken any antibiotic within 3 months. Amoxicillin 1 gram 3 times a day is given. With comorbidity or antibiotic use within 3 months, we give co-amoxiclav 1 gram twice a day along with azithromycin. Azithromycin is given 500 on day 1 and 250 milligram per day for next 4 days. Or instead of azithromycin, we can give doxycycline as well. Skin and soft tissue infections, cellulitis is present, we will give cephalexin or clindamycin. Necrotizing fasciitis is there, then we have to give IV antibiotic piperacillin and tazobactam along with clindamycin. Abscess is there, then clindamycin or co-amoxiclav will be a better option. They cover anaerobic organisms as well. Intra-abdominal infection, depending on the etiology, we can give azithromycin if cholera is the etiology, because cholera we can go for that wet mount where the motile bacteria will be present. So azithromycin single dose is sufficient. Shigella, there will be a dysentery, ciprofloxacin twice a day for 3 days. Amoebiasis, metronidazole is given. Giardiasis, again metronidazole is given. Campylobacter infection, azithromycin for 3 days is given. Bone and joint infections, methicillin sensitive staph aureus, flucloxacillin is preferred. While if it is methicillin resistant staph aureus, then vancomycin is given. Urine tract infections, cystitis is there, so it can be a uncomplicated cystitis or complicated cystitis. All those definitions we have covered in the urine tract infection video. So uncomplicated, we give nitrofurantoin or phosphomycin. Phosphomycin comes in the form of a sachet, so one sachet single dose with 1 glass of water will be given. Complicated means it is present in males or it is present in comorbid conditions like diabetes or any structural kidney disease is there or any stones are there. So ciprofloxacin twice a day for 5 to 7 days. Pyelonephritis is present. Now, how will we suspect it is cystitis or pyelonephritis? In cystitis, there will be more frequency of the urine and suprapubic pain will be there along with dysuria. Pyelonephritis is associated with chills and flank pain or renal angle pain. Uncomplicated, ciprofloxacin, and complicated, we give piperacillin IV TDS 4.5 or ertapenem 1 gram IV OD for 10 to 14 days. Now, if you have any questions related to those treatment aspect of infections, then you can put in the comment section. Thank you.